Um, is we'll talk later.
Hello,
Hi, Isabel.
nice to see you.
Likewise.
Thanks for organizing us, Izzy.
Sure, it's my pleasure. We have about 50 people who RSVP'd to attend.
Yay, that's great.
Does Dennis have screen sharing capability?
It looks like I do.
Wonderful.
So, Stephen, the CFAR scholar, so she has an interest in sort of behavioral research, which is great.
Yeah.
And she works very closely with Kevin Favor at Lincoln.
Okay.
Yep.
Great.
I'll send her her information now.
Hey, Keith.
Hey, Stephen, thank you for leading us off here.
Yeah. No problem.
And hi, Dennis. Hi, Florence. Hi, everybody.
Megan, will you have any announcements at the end of the talk for Pisces?
No, I think we're good.
Okay.
We're delighted to have you here. I want to give you as much time as you need. So I'm going to turn it over to you and go on video mute.
Okay. So it looks like it's noon, so I think I'm gonna go ahead and get started. Good afternoon, everyone. Thank you all for being here today. My name is Stephen Meanley, and I am one of the co-directors for the Penn Center for AIDS Research's Implementation Science Scientific Working Group, which you may also know as iSphere. Today's event is co-sponsored by iSphere and the Penn Implementation Science Center at the Leonard Davis Institute here at the University of Pennsylvania. So today we have a very special guest, Dr. Dennis Lee, who will be talking about his work in HIV and implementation science. A little background about Dr. Lee. He is an assistant professor at Northwestern University in the Department of Psychiatry and Behavioral Sciences and at the Institute for Sexual and Gender Minority Health and Wellbeing. His work centers on the application of implementation science methods to help end the HIV epidemic in the US. Within HIV prevention, he focuses on the development and delivery of digital sexual health programs for adolescent and young adult sexual minority men. So thank you, Dennis, for being here. We're really excited about your talk, and I'm going to hand it over to you.
Wonderful. Thank you all so much for having me today. I'm very excited to speak to you, and if you'll just bear with me a moment while I get my slides shared. Can you all see those?
Yes.
Wonderful. All right. Well, hello again, and thank you. As was just said, my name is Dennis Lee, and I use he, him pronouns, and I am an implementation scientist at Northwestern University. And part of my work is, well, all of my work kind of sits in this intersection between HIV and implementation science. Part of it is in using implementation science to end the HIV epidemic, which corresponds to kind of the top portion of my title today. And then the other half of my work is around helping other people use in HIV use implementation science, which is what the second part of my title was alluding to, how to integrate. One of my goals today is to help you all think through how to integrate implementation science into your work. And I believe I have two separate audiences or there are two different groups that are kind of co-sponsoring this talk. And so as I was developing the slides, I was thinking about two very separate audiences. So some of the things may seem very familiar to half of you and not the other half, and vice versa. So bear with me if there's some more basic material in here. Let's go ahead and get started. So just to say that I have no conflicts of interest to disclose, and this work is funded by the NIH through various mechanisms. But hopefully by the end of this presentation today, you all will be able to kind of describe why HIV is a leading domain in implementation science, identify some basic concepts of implementation science if you're new to that area, describe two examples of HIV implementation science from my work that I'll be telling you about, and then identify some resources to help integrate IS into your work. I'm planning to keep this fairly casual and leave a lot of time for questions, because I really think that interaction piece is what will help drive some of these concepts home. So first, I wanted to do a little bit of making the case for more implementation science in HIV. And then I will use an example that people in the HIV world are very familiar with, which is pre-exposure prophylaxis. But for those of you in the audience who are not HIV researchers or scientists, I'll give you a little bit of background about that. So PrEP is primarily taken in the form of a daily pill, but it has a couple other forms that are coming out. Is when you take it as prescribed, it reduces the risk of HIV acquisition by 99%. And if I were living in an ideal world, I would think, wow, this is like a near bulletproof drug. So if we have this in hand, why do we even have HIV anymore, right? This 99% is almost perfect. But that's the difference between what an intervention challenge is, which in this case, we don't have an intervention challenge. This intervention is very strong, and an implementation challenge. So of the 1.2 million people in the United States for whom PrEP is recommended due to various risk factors and characteristics, only about 25% of the people were just prescribed it. That doesn't even talk about who's actually taking it, but only about 25% of people who are prescribed it. So this represents the implementation challenge here, where we have something that works really well, but not everyone is using it. And we've seen plenty of other examples, especially in recent years with COVID vaccines and testing that that are in the same vein. In addition to just the overall 25%, there's a massive disparity here by race, ethnicity, and so equity is a massive portion of this implementation challenge, where you can see that among white Americans, people are doing decently well with coverage, PrEP coverage. 66% of people who need it are prescribed it, but among Black and Brown communities, that number is really just sad and horrific. So thinking about this in a different way, and I'm going to use a hypothetical example here to continue to make the case for implementation science. We have this evidence-based intervention PrEP, which is more or less 100% effective. And but if we start thinking about all of the different things that need to get through implementation, what if hypothetically only about 50% of providers in the country and organizations adopted PrEP, meaning they'll even have the ability to deliver it, and 50% of providers actually prescribe it when they meet a patient. So implementation's only about halfway. Let's say our dissemination efforts only get to 50% of the target population, so we don't even see 50% of those people in PrEP clinics. And then over time, only 50% of these organizations or agencies keep delivering PrEP, and 50% of the target population kind of maintains using PrEP. What ends up happening is you'll quickly see this this effect from 100% drop drastically to 6.25% for a population benefit. So again, highlighting the importance of implementation, because we have something that works, but we have lots of steps along the way for things to falter. In the United States, HIV is a disease that has only implementation challenges, more or less. We have, based on decades of research, really highly effective tools, from rapid testing at point of care or home-based testing that's very accurate. Our treatment for HIV is spot on. We have, for those of you who are not in the HIV world, you may not have heard of undetectable equals untransmittable, but if you take your HIV medications as prescribed, then your viral load is suppressed and you will be unable to transmit the virus. We just talked about pre-exposure prophylaxis, which when taken as prescribed is very highly effective. We have great community engaged models of care and prevention, and we have lots of infrastructure in laboratory and epidemiological surveillance to track how all of this is happening. But we still have this persistent epidemic of HIV because of these implementation gaps. We have a little over 1.2 million people living with HIV, 13% of whom don't know their status, 50% of whom are not retained in care, and therefore are less likely to be using their medications, and 43% are not virally suppressed. And so we still continue to see, over some 2015 to 2019, here's some slightly older data, we still just this plateau of new infections. and implementation is really the culprit. So because of that, in 2019, the US came together in the Department of Health and Human Services, developed this Ending the HIV plan, Ending the HIV Epidemic Plan, with these pillars of diagnose, treat, prevent, and respond. And this goal of reducing new infections by 75% by 2025, and reducing new infections by 90% by 2030. And this is a whole of government effort where all of these agencies in the Department of Health and Human Services were aligned together under one common plan. And for its part, the NIH, as the research arm of DHHS, funds the research to determine the optimal implementation of proven HIV treatment and prevention tools. The goal is to take the lessons learned from what the NIH funds and distribute it to these other agencies that actually push out services to the US population. And in this context, is what I'll be talking about for the rest of the talk. So NIH EHE funding has so far come in the form of three big buckets. Annually since 2019, they've released these Center for AIDS Research and AIDS Research Center supplements. And down below, you'll see a map from the 2019 funded projects. There were 65 of them in 2019. Up at, I think as of now, we have somewhere over 200 or so. They funded coordination and support for all of these disparate projects to help get everyone on the same page with implementation science methods, and to learn across all of the projects that are happening, the 200 some projects. And you'll see here ISKI, which I'll be talking about in the middle in a little bit. ISKI is central to the coordination effort. And right now there are 9 different implementation science support hubs around the country that provide support and resources and technical assistance to projects. And then later on, the NIH started funding actual large research projects at the RL1 level. In FY21, they funded 3 different RFAs for treat, prevent, and respond. And in FY22, they had a focus on social and structural determinants of health. And we fully expect more RL1s to be coming down the line. So in that context, I wanted to tell you about some applications of implementation science to HIV treatment in particular. Before we talked about prevention with the PrEP example, and now I want to turn to HIV treatment using 2 of my ongoing projects, Clears HIV, which is an EHE STFAR supplement, and then Cease HIV, which is an EHE RO1. But in order to do that, I have to give you, or for those of you who are not implementation scientists or not familiar with implementation research in the room, a very brief crash course on some of the terminology and the focus of this research. Hopefully most of you have seen something similar to this before, but just in case there's someone in the room who has not, intervention research, which is typically focused on the effectiveness of some promising intervention. As you can see in the diagram on the left, we have the promising intervention really highlighted in the front, which is the focus of the research. And then in the background, you have the delivery system. This is in intervention research, typically controlled and unmeasured. It is just something that is there. And our focus is entirely on this promising intervention, and we're trying to evaluate its health outcomes, its effect on health outcomes. For implementation research, however, we really flipped the script, and the intervention, which is now hopefully evidence-based or has some promising evidence to it, and falls into the background and we don't focus on it as much. And the focus really is on this delivery system that is in the background, and trying to understand what strategies in the delivery system really help achieve feasible implementation, adoption, help reduce costs and increase implementation with fidelity. So it's a much higher level of systems thinking in this type of research. To break down some of the jargon that we use in implementation science, the intervention, the practice, or the innovation, the evidence-based thing that improves people's health, we call that the thing. Therefore, implementation is going to be doing the thing. And I will say this is language that even hardcore implementation scientists use with each other all the time. It just helps cut through a lot of the terminology that we sometimes get too hampered in. So implementation is doing the thing. You have a thing and you want to do it. Implementation research is looking to how to help other people do the thing. So then we're going to define an implementation gap, which is, where is this thing not getting done? And implementation determinants explain kind of why this thing is not getting done. These are the contextual factors, the barriers, the facilitators in that context that are either make it easier or more difficult to do the thing. We have implementation strategies, which are what we can do about why the thing is not getting done. So actions that we're taking that help address those barriers and facilitators, and then implementation outcomes are how we know we made a difference after we've implemented some implementation strategies. To kind of put it in a more visual setting, I call this the critical components of an implementation research project. It's always centered on a thing that you want to implement. And then you go through some of these components. You always have an implementation partner. These are the other people that you're trying to get to do the thing. Your implementation gap is, again, kind of where the thing is not happening. And that informs the stage of implementation research. If you don't know very much about why something is not happening, then you might want to be on an earlier side of implementation research. If you already know kind of why it's not happening and you want to do something about it, then that moves you further down the stage of research. And again, we already talked about implementation determinant strategies and outcomes. And just to break it down, the hexagons in gray kind of provide the background of the reason why you're conducting a study or a project, and the things in red are the constructs that you want to be measuring in the study. And thinking through all 6, 7 of these things is what helps you pick your research evaluation design. Your randomized control trials, cluster randomized trials, things like that. So lots of components to think about as you think about a study. Anyways, so to move through kind of the theoretical components, I wanted to give you 2 examples of how we use implementation research on the ground. So the first project I'm talking about is a couple of things out of the way. CLEARS HIV, which stands for Configurations of Linkage, Engagement, and Retention Strategies for HIV. And this is an example of a project that is in an earlier stage of implementation research. So understanding the strategies and the determinants that are happening. We know that sustained HIV care, which is the thing in this case, for people with HIV is critical to achieving their viral suppression and ending the HIV epidemic. And agencies provide a lot of linkage, retention, and re-engagement strategies to improve that care engagement. Those are the strategies that we're going to be talking about. But in the literature, we have challenges to scaling up those care engagement strategies because we don't, oftentimes in the literature, we just talk about care engagement or linkage or retention, and they're actually fairly complex and have lots of components to them, often not well specified. And so it's hard to compare what's happening in one study versus another. And then different care engagement strategies may work for different people in different contexts. So your warm handoffs and patient navigation will work for some people, but maybe not for others. So our attempt in CLEARS HIV, or our research question behind CLEARS HIV was to understand what strategies are, under what conditions, result in higher care engagement. Here's the research team, which I will not go through in detail, but I co-PI this work with the NetMembo at Northwestern. This one is as an EHE supplement. It's a fairly short project, so it's a 1-year mixed methods collaborative implementation research study where we're working with agencies in the Chicago eligible metropolitan area that provide linkage, retention, and re-engagement services for people in need of HIV-related care. So they either will be living with HIV or and need to be in care, or they need other support services that help them stay in care. And the goal is to characterize what strategies or activities are being used on the ground in different settings and different populations in order to inform, elevate, and disseminate kind of the best practices back to these agencies, to the Chicago Department of Public Health, and hopefully, ultimately, to other jurisdictions as well. The project aims are, again, to characterize the discrete strategies and determinants that are happening within these agencies and testing providers, and then to determine some of the configurations of what these strategies and determinants and how they associate with reach outcomes. I forgot to mention that both of the projects I'm talking about are ongoing, so we haven't quite gotten to aim 2 yet. So I won't be presenting on results today, but more of kind of just thinking through how to design a study using implementation research methods. Our partners are agencies in Chicago that serve large numbers of people living with HIV, have high case reporting based on lab reports. We're looking at both publicly and privately funded agencies, as well as our attempt was to get the entire universe of these providers in Chicago. And we were decently successful. We ended up getting 24 out of the 30 agencies, and we interviewed 59 individuals from those agencies, at least 2 from each, 1 frontline staff person, 1 manager. And then they also participated in a network survey to try to understand a little bit more about how they're connected with each other. So ultimately, once we have all of the interviews done, and there's a lot of data that we're parsing through now, but once we have gotten down kind of our conclusions, we want to disseminate the findings back to the agencies as well, and facilitate learning sessions where they can talk to each other about our results and findings, so that everyone can kind of learn from the science and learn from each other. For time, I won't go too much into detail about the sample interview questions, but we asked a lot about organizational characteristics, in terms of things like their mission, the types of services they provide, the number of staff they have. These are typical determinants in implementation research. And again, determinants are the reasons or the factors that might explain why implementation is going well or poorly. Then we ask tons and tons of questions about their linkage, retention, and re-engagement strategies. You know, what does this mean to you? What is your organization or agency's definition of it? What is the process in which you lead clients through linkage, retention, or re-engagement? Who is doing it? When does it happen? How long is it taking? How many times do you do it? Do you have a protocol that you're following? Things like that. And then we ask about implementation supports. And again, these are more of those contextual barriers of facilitators around, you know, what's happening on the ground? Do they get training? Do they have written protocols to follow? Do they have resources if they have questions? Does the staff, or does the agency shift workflows or tasks if they're understaffed? Lots of kind of pretty pragmatic questions. These were developed from kind of baseline conversations with some of these agencies around what's happening on the ground. And then all of this in the background is kind of is captured in this implementation research logic model, which looks far more complex than it actually is. It's just a way to dump information. And I'll be talking about this kind of later down the line. But this is kind of a depiction of everything that's happening in our research study. Now, the second example of an HIV-IS study that I want to talk about is a little bit further along in the implementation science continuum. This one's at the implementing and testing strategy stage, and it's called CEASE-HIV, or Collaborative to Enhance Access for Suppression to End HIV. Again, in the background, you know, sustained HIV care for people is critical for helping them achieve viral suppression. And Chicago is generally doing well in linkage, but retention and viral suppression are, as you can see with the red diamond is Chicago. Retention and viral suppression are lower than linkage. And that's especially true for these population-centered health homes, which is the public safety net clinics in Chicago. There are 12 of them called PCHHs. And for some reason, the population-centered health homes, which already tend to serve, you know, individuals with more complex needs, are not doing as well as Chicago as a whole. And part of this reason may be that people with HIV who are not virally suppressed, the ones that we're not currently reaching, have lots of individual barriers to engaging in care. So, and we're referring to these this population as people with complex needs. some of this I already covered. The population of interest in this study is people with HIV, especially those with complex needs, and that means people who are experiencing multiple social determinants, potentially mental health and substance use challenges as well. This is again taking place in the Chicago EMA, which is an EHE priority county, and the setting is those 12 population-centered health homes, which are the public health safety net clinics for HIV, which provide a lot of in-house clinical care services, but also a lot of wraparound services like substance use treatment, mental health, psychosocial services, testing and screening. In this case, we're shifting the focus of the thing, because what we want to implement this time is a strategy in itself called low barrier care. It's a complex strategy. It's a package of activities developed specifically for people with HIV with complex needs to help them stay in care. And this was developed in Seattle in what's called the Max Clinic, or the Max Clinic model. And it did show effectiveness or evidence of effectiveness on viral suppression for people with complex needs. But it was implemented as a standalone clinic. And so for our purposes, we, in order to kind of reach across the catchment area, the wide catchment area that is Chicago, we are wanting to integrate low barrier care into the 12 population-centered health hubs. This table over here tells you a little bit about what goes into low barrier care. So they have to have low barrier access, which means walk-in medical care and walk-in case management. They have to have high intensity support, so case managers with really low caseloads, high incentives, so a reason for people with complex needs to come into care and prioritize care over something else. Oftentimes that is monetary, but also food and kind of other services that they want, and it should be identified from the patient population or the client population. Intensified case coordination, and then also coordination with transitional care. So these are some of the aspects of the low barrier care clinic in Seattle called the Max Clinic, and we are trying to move that into Chicago, and therefore the thing in our case, the thing that we're trying to implement is low barrier care. We did a lot of working with our implementation partners early on, and specifically Chicago Department of Public Health. We made them aware of low barrier care. We talked a lot about it. And so through a series of conversations around sorry about the acronyms, their Getting to Zero or their EHE priorities, we said, okay, tell us what you want. What are your priorities for ending the HIV epidemic? And then we matched those priorities to, oh, here's a model of low barrier care that could help meet those priorities. And so this project was really driven by CDPH as much as it was driven by us as researchers. And so got the public health department to commit to low barrier care pretty early on. And then together wrote this EHE R01 to get funds to actually implement low barrier care. So part of the implementation process that we were trying to be as pragmatic as possible. And what that meant was to get CDPH to commit to supporting low barrier care in their next request for proposals from these public health clinics. Our timing just happened to align so that all of the 12 PCHHs have to reapply for funding in a year or so. And so we wrote this R01 to kind of piggyback on that timeline and say, we're going to take some time to use a learning collaborative, get everyone on board, understand how to implement low barrier care, and then when it comes time to for funding, CDPH is committed to funding them to do low barrier care. And so we end up for this project in an interesting place. By we, I mean us at Northwestern, as both the conductors of this learning collaborative, and then also doing the research study on the side, studying how and why and what in terms of getting these 12 agencies on board with low barrier care. So our aims in this case were to facilitate adoption, adaptation, and implementation of low barrier care strategies by the 12 PCHHs using a learning collaborative. And then we are going to, once some or all of them are funded to do low barrier care in their next round, evaluate kind of site specific and then the system-wide effectiveness of low barrier care on improving care engagement and viral suppression at the city level. And then finally, we want to kind of dig in further into around implementation costs and sustainment to make sure that these strategies can continue to be used once this research project is over. Generally, the timeline in the study design is fairly simple. We have about a year where we are kind of looking at what they're currently doing in their agencies. We, through a learning collaborative, we tell them about low barrier care. We help them work through what needs to change in their agency in order to, adopt walk-in access, increase their incentives, go down to lower caseloads for a subset of the population. And then at the end of the year, CDPH is going to release their new request for proposals that includes kind of what the agencies have identified as their low barrier care strategies in the proposals. And what I mean by that is we're using this learning collaborative as an opportunity to not only teach the agencies about low barrier care as an evidence-based intervention, but also, an evidence-based strategy, but also have them all collectively adopt it for their own agencies. And so that kind of core adapted model goes into the CDPH RFP, which then the agencies apply for. So this was a huge selling point for the agencies in participating, because they very rarely do they get a chance to plan implementation and also contribute to what they will ultimately be applying for. So that was a huge part of the success for getting them on board. Then in the future, once the learning collaborative is over and once some of the agencies are funded for low barrier care, we're going to have an implementation ramp up period. And then for 2 years, we're just going to follow and measure their levels of sustained care and viral suppression. All of these are using data from all of the kind of the outcome data are coming from surveillance data and programmatic data. So we actually don't have a huge data collection burden from the agencies either. And we specifically did that because we wanted to be as pragmatic as possible. We wanted to not overburden them with data collection. And trying to find, I think, creative data sources to do that, and creative data sources and creative study designs to be pragmatic and reduce research burden, I think is a key part of implementation research. And again, this whole project has an implementation research logic model that is kind of underpinning it as well, which I'll, and these, again, this is the implementation research logic model is a really nice tool to visualize everything that's happening in one study. But for the uninitiated or the people who are not familiar with them, they certainly can look very overwhelming, which is why we'll next go into tools to help you do some of this research. I realize there's some questions in the chat, so I'm going to take a quick look to see if I can answer any of them. Let's see. Where does the WHO fall on this list? I might have to come back to that one because I may have missed when the list was. What proportion of clients at PCHHs receive Brian White services? It's going to be most of them. PCHHs serve, are, as I mentioned, the safety net clinic system in Chicago, and so most of their clients, or a large proportion of their clients, are going to be receiving Brian White funding. And I wonder what theoretical IS framework you applied to for the project. That's a great question, and I try to avoid going into the details of frameworks and theories in this case, but I know half of you are implementation scientists, so I'll mention that for barriers and for determinants, we frequently use CIFR, or the Consolidated Framework for Implementation Research. For strategies, we mostly we try to follow the ERIC taxonomy to select some strategies, but oftentimes the HIV activities don't really fit those really well, and so we kind of went off book quite a bit. For outcomes, we used a combination of both Proctor and REAIM. And here you can also see for this R01, we also used EPIS because there's a time component. And for those who are not in implementation research, it's pretty common to use lots of theories and models and frameworks for different parts of your study. And I'll also kind of talk about that in a second. But thank you for those questions. And I'll try to leave time for more at the end. I think I'm doing okay. So with kind of my thinking with giving you two examples from my own work research that is both ongoing is less about the specifics of the studies themselves, but more about thinking through pragmatically in your work, particularly in HIV, where can you insert some implementation science questions? You could be studying the process, which was more like Clear's HIV. Something is happening and you just want to understand what is happening, why it's not working, why it is working. And so you can have more of an observational type study in that way. Or if you actually have the resources, the political will, the implementation partners on board to change implementation, then you can design an actual project that is prospective and tweaks the service system to improve implementation. But it doesn't always have to be your what I call like super high level designs of cluster randomized or rollout trials or step wedge. It can also be natural experiments and very pragmatic pre-post interrupted time series designs that don't put a lot of burden on the system itself, but is still rigorous enough to give you the data that you're looking for. So next I want to turn to kind of some resources for you all, both who are implementation scientists already or who are burgeoning implementation scientists, to add to your own work. And all of this comes from our ISKI EHE CFAR supplement. As I mentioned before, one of the things that NIH has funded as part of EHE has been coordination and technical assistance centers. And this has come in the form of ISKI, the Implementation Science Coordination Initiative, which kind of helps coordinate across all of the funded EHE supplement projects, and then 9 technical assistance or implementation science support hubs located around the country that help individual projects or individual researchers improve the rigor of their implementation science methods. The aims of this entire initiative together are to support high quality implementation science in funded EHE projects through coaching and technical assistance. That's used to be done centrally by ISKI, but now is done primarily with the 9 hubs. And then to create opportunities to develop generalizable knowledge from local knowledge through measure harmonization, data synthesis, and cross-project collaboration. So as you can imagine, with 200 projects funded across the United States in different jurisdictions, different contexts and settings, there's still a lot to be learned from that variation and from the similarities as well. And so the role of ISKI primarily now is to take all of these projects, find opportunities where we can kind of learn from each other, and get everyone using harmonized measures and frameworks so that we can actually develop some generalizable knowledge instead of 200 individual pieces of knowledge. One of the ways that ISKI and the hubs have been supporting this work is through our more or less recently relaunched website at hivimsi.org. I'll have a QR code at the end as well for you to go to, but feel free to hop on when you can. And this is a large resource repository, as well as a repository of plenty of tools to help you do implementation science work. Not always in the context of HIV, certainly that is the main focus, but the tools can be fairly content agnostic. And so even those of you who are not HIV researchers may find a lot of use here. For the folks who are less familiar with implementation research and need more of a primer, we have 2 kind of walk through curricula. One for practitioners on how to consume implementation research or how to understand implementation research when implementation scientists are talking to them. And then the other for researchers who are looking to start an implementation research project. And kind of the hexagon diagram that I showed way at the beginning of this talk, it walks you through these steps and saying, okay, try to identify your implementation partners. All right, next, let's identify those implementation gaps. What's happening, what's not happening. Let's find the next, identify what stage of IR you're in. And so we have some decision support to help walk through those that thinking and planning process. We have, as I mentioned, a resource repository with just a lot of helpful things that we've found over time, and also presentations from previous ending the HIV epidemic conferences, and talks and seminars. And we, as I mentioned, we have a lot of different tools to help people do different aspects of implementation research. And I'll highlight 3 of them very briefly before I break for additional questions. So the first one is a literature review dashboard. One of the things that ISKI has been doing a lot is combing through the HIV literature for various different interventions or things, and trying to identify what are the barriers and facilitators that have been studied, what are the determinants that have been studied before, and what are the strategies that have been studied before. And certainly, we're producing these systematic reviews, but we didn't think just having a published paper really, does enough for the field. And we've turned all of the data that we've come through and coded hundreds and hundreds of papers into this dashboard, which is going to be continually updated. So here's an example of what the dashboard looks like. Currently, it has data from our PrEP implementation review, PrEP determinants review. So the barriers and facilitators to implementing PrEP around the US. And we'll soon be adding strategies for PrEP. We'll be adding determinants for testing and linkage. We'll also be adding strategies for testing and linkage over time. And all of this will be continually updated as we move along. What's nice about the dashboard is that people can kind of click around on various things. It's very dynamic, so you can focus in and sort. You'll see we have a count of articles that are included in the dashboard. You'll have a count of the determinants that we coded from those 239 articles. And you can filter down by, for both the practitioners or researchers, if you are interested in African-American adolescents, in community settings in the South, you can drill down to that level of detail and find both, you can export both the actual articles themselves and the data that we collected from those articles. So this is a way that we thought we could democratize some of the research that is out there and help both researchers kind of identify gaps in the research that need more focus, and help practitioners kind of figure out what do we know and what already in their setting. Another tool that we have on the website is the implementation outcomes crosswalk. As I said, a lot of our focus is on harmonization of measures, and implementation outcomes is one of those things that is, doesn't have a lot of, we have some frameworks that tell us broadly what we should be looking at, but not a lot of guidance as how to operationalize down to what to measure. And so we've developed what we call the operationalization guide, or more colloquially known as the HIV crosswalk, outcomes crosswalk, through a number of different methods to develop it. And it currently takes the form of a giant spreadsheet that uses the RE-AIM framework, so 5 dimensions of RE-AIM, and then drills down by kind of the level at which something should be measured, the pragmatic implementation question that is being addressed by this outcome. So we wanted it to be very pragmatic in that someone who is trying to identify their gap, why something is not happening, can look and match their question up to this crosswalk rather than figure it out and match the constructs up. So that finding the question that matches your implementation gap. For each question, we have a number of standard constructs and considerations or recommended scales that we tell people to use. And then we have also a rating of importance by stage of implementation research. So if you are piloting something, if you're just understanding barriers and facilitators, you don't need outcomes for everything. So there's a lot of not applicables, if relevant, kind of through the crosswalk. But if you're trying to bring something to scale, or you're trying to test a strategy, then certain things will be more important to measure or not. And I know I'm going at a very high level of these tools here, but it's trying to give you a taste of what is on the website. And finally, to get to the implementation research logic model, for those of you who were very kind of overwhelmed by the two earlier, as I mentioned, and per the question that was posed in the chat, implementation science uses tons of theories, models, and frameworks, each for different purposes. Some describe the process of doing implementation, some describe the why, so the barriers, the facilitators, the determinants, and some tell you what to measure on the outcome side. And any implementation scientist knows that I think right now there's like over 114 barriers and facilitators identified in the literature. And so there's a kind of, it's a bit overwhelming for anyone trying to get into it. What the implementation research logic model does is it's not a model in and of itself, but it's a way of kind of putting all of the models and theories and frameworks that you have to use into nice little boxes, and tells you how they all relate to each other. So you have one for determinants to guide, the barriers and facilitators of why your thing is not happening. You have a box for the thing itself to help you determine and specify what it is you're actually trying to implement. You have your strategies, which are the actions that you do to address the determinants in order to improve implementation. And then you have your outcomes that help you understand why or how well and how much you are improving implementation. So on our website, we have a lot of templates to help folks create an implementation research logic model for themselves. We also have a number of previous seminars and trainings and workshops on the IRLM that we've done that are recorded. And we are in the process of developing a kind of a decision support tool where people can click on things and actually fill it out online, and it will generate and populate a beautiful IRLM for you that is tailored to your research project, and your team members can go in and work on the same logic model as well. So be on the lookout for that. That'll probably be developed kind of by the end of the year. So with that, I'll end for questions. Again, our website address is hivimsci.org. You can email us at isky@northwestern.edu. And I believe this QR code will take you to, I forgot to mention, we also have a bi-weekly newsletter called the ISKY Interchange that has resources, opportunities, newly published research in HIV implementation science, lots of different cool things, infographics on what the projects are currently finding. So please follow the QR code and sign up for our newsletter. With that, I'll take any questions that you have.
Thanks, Dr. Lee. Do you want to unshare your screen so we can all sort of see each other?
Whoops, that would be my video.
And that was such a fantastic talk. And I think as a consumer of many of the resources you talked about, I can attest that they are incredibly helpful. So I think there were still a couple of questions in the chat. And I'm going to go back to, I think, the question that Javante had posted. I think his question, where does the WHO fall on this list, was when you were talking about identifying what is the intervention versus what is the strategy, that list.
Yeah, I'm just going to add a clarification. That was the question, Stephen. Thank you so much for a wonderful talk. These resources are going to really help us at the health department, even though we are not implementation scientists. Well, one of us is, Dr. Tana Nassau on the call. But you gave us such a helpful, like, layperson's understanding of the thing, the why. And so it had all of the questions there except the who. And I was wondering, how would we frame the who? I saw later in your slides that you mentioned settings, and so I think that may be alluding to the who, but if you could just clarify that.
Yeah, absolutely. me try to get back to that slide actually, because it might be easier to just visualize. So I believe you were, correct me if I'm wrong, but I believe you're alluding to this one. The who, I realize, are kind of buried in there. It's these others, and who, and that's not very helpful. But it's the other people that you want to be doing the thing. That could be individual practitioners or providers. That could be agencies. I think what makes a little, it shows up again here in this figure with the implementation partners. But sometimes it's really dependent on what the thing is that you're trying to implement. So for the two projects that I talked about, when we're talking about linkage, retention, and re-engagement strategies for HIV care, the who are the agencies themselves, as well as the frontline staff and managers in those agencies that provide linkage, retention, and re-engagement, not necessarily the ones that are providing care. For the low barrier care example, the who in that case were the 12 population-centered health homes. And because it is it's a multi-level strategy, that it really is it's a whole clinic change, and therefore the who is kind of everyone at every level in the clinic that might be affected by that strategy. Is that helpful? Or does that answer your question, Javante?
Yes, both helpful and answers. Thank you.
Dr. Bradley, I see you have your hand up if you want to unmute yourself.
Sure. Thank you so much. Hey, Dennis, it's Corey.
Hey, good to
I'm
see you.
so happy, yeah, that I got to witness and experience your presentation and your work. So I'm about to I probably should just call you to talk more about this, but this was great for me. The question I asked you about Ryan White is because I was interested in how you think about this issue of engagement and viral suppression when we know that folks who are on Ryan White are doing better than folks who are not. So I was just curious. That's why I was asking, so is there kind of like an emphasis on certain groups of folks who are not doing so well with viral suppression and maintaining their connection to medical care? So that was that part. The other piece that gets exciting is the Learning Collaborative is amazing. And I'm wondering some insight about the problems that folks living with HIV have around viral suppression and engagement, sometimes touch these social determinants issues, which may be perceived by the agency as beyond their control, right? So I'm wondering, how are they thinking about that? Is the Department of Public Health kind of partnering to address more of the structural kinds of issues that even extend beyond the clinic itself that would facilitate better engagement and viral suppression? Yeah.
Thank you for those questions, Corey, and really great questions that I certainly kind of gleaned over some of those details earlier. So for the Ryan White services, I will say, I want to say I'm not throwing our PCHHs under the bus at all. They are doing a phenomenal job. Chicago is doing really well with a lot of the the indicators of the HIV continuum for many people. And that includes those who are eligible for Ryan White services. There is still a subset though, the folks who even Ryan White care with all of its intensive things doesn't reach, doesn't help keep them in care. Something's just not working for them. Oftentimes it is a lot of these social determinants or multiple social determinants of health that are the barriers. And so we need something different for them. And that's where low barrier care comes in. I think I didn't really make clear, but the PCHHs will continue doing what they're doing now, but also integrate low barrier care as differentiated care. So for a certain subset of clients, not everyone, because low barrier care can be very expensive. For a certain subset of clients who are not doing well in regular, already high intensive care, what additional things, or how can we shift the structures of care for them that might get that like additional number of people who we can't get in right now. What can we do to serve them? So I think hopefully that answers that aspect of your question. And then for your second question, I have completely blanked. Can you please repeat it?
It's okay. I'll follow up with you offline so folks can have a little. I don't want to take up too much space in the room, but that's great what you provided. They're kind of linked, so we'll just follow up with each other. That's okay.
Yeah, looking forward to it.
I wanted to make sure I didn't miss a couple of other questions in the chat. So Dr. Sarah Wood here at CHOP asked, for the first project, how do you assess effectiveness of specific strategies or packages of strategies that have been adopted?
Great question, and I didn't go into it, so you did not miss it. What we're doing is actually a method called coincidence analysis, where we are getting data from the public health department, again, using kind of available or somewhat semi-available data so that as not to burden the agencies themselves. We're getting data from the public health department around kind of each agency's number of clients that they have served over a period of time. So essentially a proxy for reach. And then we will be looking at using coincidence analysis, which is a kind of a Boolean method that looks at, okay, these combinations of strategies and determinants are linked to higher reach numbers. And then, some combinations of strategies and determinants are linked to those with lower reach numbers to try to differentiate kind of what is kind of a better package versus a less good package. What a limitation of that type of method is if everyone is doing, let's say, a warm handoff, then that drops out of the model because there's no variation in that. But we are, for the outcomes, to assess effectiveness of the strategies, we're using public health data. The dashboard is publicly available. If you go on to HIVinsight.org, under tools, I believe it's called the HIV implementation literature dashboard. And it takes a while to update with new batches of research. So right now it's just the PrEP determinants, but we are actively working on getting PrEP strategies in there, and then testing determinants comes next.
And we just have a couple more questions. So Dr. Lanefall asked, or you mentioned that the ERIC strategies were of limited utility in one of your projects. Could you say a little bit more about that?
Absolutely. So in HIV, and this is, I think it's a two-way street. HIV, the field of HIV research has historically focused on a lot of client and patient-centered interventions. They're not all clinical interventions. Many of them are kind of what sometimes we call supporting interventions or adjunctive interventions. They help people stay on medication, or they help people manage their HIV status. They raise awareness of testing and HIV prevention methods like PrEP. But by themselves, if you just gave someone a medical adherence intervention, that won't change their HIV risk or viral suppression rates without the actual medication itself. So they're kind of in a supportive or adjunctive role. And that's where a lot of the field has really focused over the last couple decades. And so ERIC, being kind of a little bit more at the system level type of implementation strategies, doesn't really cover a lot of these individual level ones. It kind of all just falls under consumer engagement strategies or something there, something like that. That said, I think ERIC poses a really wonderful place to start or to move the field of implementation, HIV implementation towards, to start thinking beyond the individuals. What other types of strategies or what other types of targets do we need to be thinking of to help improve implementation of PrEP, of testing, of antiretroviral therapies that are not always targeted at the individuals?
And last question from Dr. Silvestri. For funding perspective, in the NIH subsection that evaluated your R01, was your study considered innovative in regards to the implementation science per se or not?
Oh, that's a good question. And I can't remember offhand. I will say it didn't score the best, but the project officers and our colleagues at who were also funded under the same RFA all got similar scores as we did. So it may have been a case that the reviewers just didn't quite get the implementation science pieces of it, but the project officers for all of our project officers were incredibly excited about the work, especially how kind of embedded in the public health system that it was. So I can't remember the specific comments from the reviewers, but certainly the project officers were very excited at how kind of applied and pragmatic the study was.
Wonderful. Great. Thank you again so much, Dr. Lee. Thank you everyone for being here today. This is our last iSphere event of the year. And so if you have any questions, I believe everyone has Dr. Lee's contact information. And so feel free to reach out to him. Take care, everyone. I hope you all have a lovely rest of your week.
Thank you all again for having me. It was a pleasure to speak to you.
Thank you, Dennis. Thank you, Stephen.
Thanks, everyone.
Share the